And before I call in the panelists, let me introduce to you some facts about falls in the older adult population. And these come from the National Coalition of Aging, the American Occupational Therapy Association, and the American Physical Therapy Association. So every 15 seconds, an older adult is treated in the emergency department for a fall-related injury. Every 29 minutes, an older adult dies from a fall. Every year, that equates to more than 20,000 older adults who die from falls. At least 30% of adults 65 and older living in the community fall each year, and the likelihood of falling increases rapidly with advancing age. Some more facts. Falls are the leading cause of both fatal and non-fatal injuries to those 65 years and older. $28.2 billion are spent annually treating older adults for fall-related injuries. And the good news is that prevention programs have been shown to reduce the risk of falling. Ergo, we have our session this afternoon. So let me call on our first presenter, Dr. Moseley, and she will be presenting the session on the role of medications. Help me welcome Dr. Moseley.
Good afternoon, everyone. All right, well, let's get started. Of the 4 objectives today, I'm going to be focusing on identifying drugs that will increase fall risk in geriatric patients, as well as outline some strategies that will help you mitigate fall risk. Why do older adults fall? We just heard some wonderful statistics. I've listed a few major causes here, but today I want to challenge you to think outside the box. When you look at this list, I want you to look at it from a pharmacist's perspective. I see a list of medication side effects, is what I'm seeing right here. Aside from accident and environmental related, gait and balance disorders, that could be medication related. Weakness, definitely could be. A drop attack, so a sudden fall without loss of consciousness. Confusion, definitely. Postural hypotension, that could definitely be medication related. Visual disorders, we have some medications that can cause blurry vision. Syncope, another one. So when we go through this presentation, I need you to think through my eyes, through my brain as a pharmacist, and we're going to look at these medications critically to see if we can help prevent falls in patients from a medication perspective. Medications are an independent, modifiable risk factor for fall risk. It's included in many efficacious fall prevention programs, along with exercise, medical assessment and management, and adaptation or modification of home environments. What are the strong risk factors that we're looking for? Polypharmacy is definitely going to be one of them. Did you know that as far as fall risk goes, for every medication you add past a 4-drug regimen, it increases a patient's fall risk by 14%. So in this case, polypharmacy could even be defined as 4 or more medications in that case. Psychotropic medications. I've listed some examples to the side. Psychotropic is an umbrella term to cover many different medication classes, including antipsychotics, serotonin reuptake inhibitors, benzodiazepines, and other medications that can affect the neurological system. Potentially inappropriate prescribing, this is another risk factor. And we do have tools available to us, such as the Beers criteria, or the Beers list, and the STOP criteria to help us identify those medications and steer away from prescribing them. So what medication effects are we looking for when we're trying to prevent falls? Some of these are going to be direct effects of the medication. We use antihypertensives to lower blood pressure. That's a direct effect, but some of them are also indirect effects. And some of these will look very common, and you'll think, oh, of course, that's going to be a fall risk. Confusion, sedation, hypotension, hypoglycemia is on here. Dehydration is another one. But even electrolyte disturbances, mild chronic hyponatremia is a risk factor for falls. Constipation, that may seem strange to you, but we're giving them a lot of medications that can cause constipation. And if you have a patient who's straining, that could lead to a vasovagal syncope. So even constipation could be included in this as well. Increased frequency of urination. We use a lot of diuretics. If they're running back and forth to the bathroom, we're just increasing their risk of falling again. And then muscle weakness and ataxia. What medications are we looking for? Based off of those side effects, nearly all of them, but we're going to narrow it down. I've listed some classes here to help you. You will see those psychotropic medications on here. Antipsychotics and benzodiazepines are consistently associated with increasing fall risk, but there are several other medication classes on here as well. Many antihypertensives, diabetes medications that can lower glucose levels, as well as anything that can impair cognition. So this is not by any means an all-inclusive list, but it's just a list to get you thinking, and it will be helpful when we go through a patient case at the end. What do we do? My stance on this, and I hope yours is too, is less is always more in this case when it comes to medications and preventing falls. So we want to minimize the number of medications, so working to get rid of all of the excess medications that the patient may or may not need anymore. And then as far as psychotropics go, discontinuing them has the strongest evidence for preventing falls, but if you can't discontinue them, some patients do need antipsychotics occasionally. At least reducing the dose would be helpful in this situation to reduce the risk of falls. Just a quick audience poll, just raise your hand. Has anyone heard of the palliative geriatric practice algorithm before? 2 people. Good. You're going to learn something new today. Wonderful. You came to the right class. I think this is an excellent algorithm. It's a patient-centered approach to deprescribing is the way that best describes it, and it is available in your packet that you were given today. It involves the prescriber, but this is also an excellent opportunity to involve interdisciplinary team members in this approach. Pharmacists would be helpful as well, but even including nurses, the prescribing physicians, anyone who's involved with the patient's care to get their input on what is important to the patient and the caregivers versus what we know is evidence-based medicine and what the patient should be on. So starting from the top, evidence-based medicine is what we're focusing on first. Is there a reason why the patient needs to be on this medication to begin with? If you're not sure, we go down to the next one. What about the indication? Is the indication valid and is it still current? I had a patient this week who was taking gabapentin for some neuropathic pain he had from shingles 2 years ago, but he hasn't had any neuropathic pain since. So is the indication really still relevant at this point? So we want to revisit that. What about the adverse reactions they could experience? This is a risk versus benefit conversation to have with the patient. Also, is there another drug that could possibly do what we're trying to achieve better with less side effects as well? And if at all else you determine that the patient really does need to be on the medication, are they at the lowest effective dose possible? This is very important when especially when you're dosing antipsychotics, doing gradual dose reductions as well. So this is a good approach. So we're going to meet Mr. Wilson. He's a 76-year-old man who's referred to your outpatient falls evaluation clinic by his primary care provider. All you know is that he's fallen 3 times in the last 3 weeks. His past medical history includes type 2 diabetes, BPH, hypertension, hyperlipidemia, depression, and osteoarthritis. And this is his list of 12 medications. This looks like a typical patient list, wouldn't you agree? Maybe if he had COPD, then it would be complete. But I think for right now, this is a pretty good list. This is something we commonly see. Now, when you look at this list and the patients coming in for falls, I want you to look at each one, and we're going to go through them quickly together, but I want you to know the way that I'm thinking as I see this patient's list. I see metformin. Metformin alone doesn't cause hypoglycemia, but he is also on glipizide. So glipizide definitely can lower blood pressure or blood sugar. So we want to ask him about signs and symptoms of hypoglycemia when he comes in today. Furosemide is a diuretic. He's going to be going to the bathroom frequently. And then also, why is he even on furosemide? I don't see a history of heart failure or peripheral vascular disease. So that's something we want to investigate. Why was that medication even started originally? Amlodipine could actually be possibly the reason that the furosemide was started. One of the adverse effects of amlodipine is that it causes lower extremity edema. So we could be seeing a prescribing cascade, a medication that was prescribed for the side effect of another medication. So, but amlodipine can cause low blood pressure. Furosemide could lower his blood pressure too. And now we also have lisinopril. So maybe this was hypotension or orthostasis. So that's something we're going to look into as well. We talked about glipizide. Now trazocin or terazosin, however you prefer to say it, he's taking it mainly for BPH, but it does have effects on blood pressure as well. So now he's on 4 medications that could potentially affect his blood pressure. So that's definitely something we want to look into today. Citalopram. In recent literature, SSRIs or selective serotonin reuptake inhibitors have been associated with increased fall risk, so that's on our list as well. Simvastatin can cause muscle weakness and muscle pain. That could be on our list as well. We're almost hitting every single medication so far. Hydrocodone, definitely on our list of worries as far as falls go. Aspirin, not so much as long as he's taking that enteric tablet and nothing else. Docusite, he's buying this over the counter, so something's going on. He's having constipation, and then he seems to be having problems sleeping at night because he also bought some Tylenol PM. And many people aren't familiar with the fact that Tylenol PM not only contains acetaminophen or Tylenol, but it also contains diphenhydramine, which is Benadryl, and a very anticholinergic drug. But all he wanted to do is take something for sleep. But now he's taking 2 Tylenol-containing products. So let's go into some case scenarios. Now we're going to get a little more information from the patient. What if the patient tells you, you know, I was actually on my way to the bathroom and I fell down. Okay, he was on his way to the bathroom. Was this his first trip? Was this his 10th trip of the day? Could it be the diuretic that's making him run back and forth? Did he fall right after he stood up? Could this be blood pressure related? So we need to investigate that. Possibly we need to reduce some of his antihypertensives today. So there's a lot of different things can go. Fell in the bathroom. What if he was in the bathroom and fell? The constipation comes into place. If he's straining, he could have had that vasovagal syncope. That could be an issue. He is on an analgesic that can cause constipation, and he's only on a stool softener. So we might be able to help him out that way. So do you see how all of these things are coming into play? And this is only medication-related things, but it gets looked over quite often. He fell when he got up at night to go to the bathroom. So again, was this upon standing? How many times is he getting up at night? Maybe it could be the diuretic he's taking, but maybe the trazocin for his BPH isn't working very well either. Trazocin, we said, also has effect on blood pressure. Maybe we need to switch him to a more selective drug such as tamsulosin, which is less likely to cause the drop in blood pressure. So we've got some options to optimize his therapy to reduce his risk of falling. Now, what about, he said the room was spinning just before he fell. I would start looking into those blood pressure medications again, checking orthostatics in him to see if it's when he stands up, he starts spinning. It could be many other things. It could be the hydrocodone affecting his neurological state. What about he felt sweaty and shaky when he fell? That is a pretty obvious one pointing to possible hypoglycemia, but that's very common for patients who are taking medications such as glipizide, which can lower your blood sugar. I also want to point out, too, with the glipizide, when you're going through the medication list with the patient, it's also very important to ask them actually how they take the medications, even though on the previous slide it said glipizide 10 milligrams twice a day. What happens if he accidentally misread that label and he's been taking 2 tablets twice a day? If you never asked him, you would never know. So sometimes we ask patients, how many tablets of that do you take a day? Do you take a half tablet or do you take a whole tablet? Just to kind of get a feel for actually how they're taking the medication. It's part of medication reconciliation. And then his thigh muscles felt extremely weak and sore. That may point towards the statin. Or it could be, I mean, if he's feeling weak, it could maybe be the hydrocodone is making him feel a little weak and sore. Maybe he's dehydrated. So there's a lot of medications that could be playing into this for him. So the point of this is don't overlook medications when you have a falls evaluation that you're looking into, because there's a lot of circumstances going into it that you could adjust just by fixing his medications. I want to go back to the list because now I want to apply the good palliative geriatric practice algorithm. Let's say he was having low blood pressure. We talked about furosemide can be contributing, amlodipine, lisinopril, and possibly terazosin. Now, the patient tells you, I don't remember why I was given furosemide. I think I had some swelling in my ankles, and then they told me to take this, and it gets rid of it. It works really well. And if we have low blood pressure, he does have a compelling indication to be on lisinopril because he has diabetes, but he doesn't have a compelling indication to be on the amlodipine. He's also not maxed out on the lisinopril either. We have room to go up on that and maybe switch him over to just one drug, possibly. And then if we eliminate the amlodipine, we may not need the furosemide anymore as well. So there's a lot of medication manipulation we can do to help reduce this patient's fall risk. So I would encourage you next time you have a patient who falls, take a really good look at their medication list and the circumstances surrounding the falls and see if there's anything medication related or any way that the medication is affecting their life that could be contributing to these falls as well. So in summary, medication use is one of the most modifiable risk factors for falls in geriatric patients. Direct and indirect effects of many commonly prescribed medications are going to increase risk, and using tools such as the Good Palliative Geriatric Practice algorithm in conjunction with the patient and caregiver's preferences, guidelines, and drug utilization review criteria can also help with medication burden and fall risk. And I would like to entertain any questions in just a moment after Dr. Espiritu speaks.
Good afternoon. I will begin my presentation today by briefly describing various types of fall risk factors. Then I will transition into describing two interdisciplinary tools that are available to assist health practitioners in evaluating the fall risk, and then conclude with a few examples of fall prevention interventions that can be used to help minimize your client's fall risk. So most falls experienced by older adults result from an interaction between intrinsic, environmental, and behavioral risk factors. So briefly, I want to review those different types of fall risk factors for your benefit. So intrinsic fall risk factors are ones that originate within a person. So these factors are both psychological as well as physiological in nature. Among community-dwelling older adults, the strongest intrinsic risk factors for falling include previous falls, strength, gait, and balance impairments, and the use of specific medications, as Dr. Moseley had mentioned. Intrinsic risk factors that are psychological in nature are a fear of falling and a low falls self-efficacy. Environmental risk factors, as I'm sure you're aware of, are hazards existing in the home or community, right? So those are things like slippery floors, not having a handrail on staircases, or obstructed hallways. And finally, behavioral risk factors. Those are ones that either a person chooses to do or something someone chooses not to do that increases their fall risk. So for instance, failing to ask for help in order to do a task safely, or potentially choosing to use an unstable step stool or something like that. Many of these fall risk factors are modifiable. I'd like to discuss something else that I'd like you to consider, and that's the idea of perceived versus physiological fall risk. Perceived fall risk is what a person believes their fall risk is, as opposed to physiological fall risk is their actual fall risk. And among older adults, there can be a disparity between these two things. And that can influence a person's behavior. So for example, a person who believes that they have a high physiological fall risk, right? They have a high physiological fall risk. However, they don't perceive a high perceived risk. What happens is they may do something that's dangerous, right? On the flip side, if you have a person who believes that they have high fall risk, but they actually don't, that might lead to changes or restrictions in their activity, right? Which then can lead to deconditioning, which then leads to an increased fall risk. So in a study that was conducted by Del Barre, they actually found that almost 1/3 of the participants actually had a disparity in their perceived versus physiological fall risk. So what does that tell us? That in a fall risk assessment, you need to have measures that look at both perceived and physiological fall risk. And based on labels that Del Barre and the other researchers came up with, vigorous, anxious, stoic, or aware, practitioners can then can develop individualized fall risk plans. And they provide those actually in the article, some specifics for that. Next, I want to transition into describing a few resources that are available that would assist you as health practitioners in evaluating fall risk, as well as providing best practice for interventions. The first is the guideline for prevention of falls in older persons. And this was developed collaboratively between the American Geriatric Society and the British Geriatric Society. It was originally designed or put together in 2001 and last updated in 2010. And this is an evidence-based clinical practice guideline that outlines what health professionals should do, both for assessment as well as intervention. So if you can consider this to be the best practice when it comes to fall assessment and intervention. So included within the guidelines is this algorithm. And you actually have in your handouts a more beautiful copy of that. But what this algorithm does is it walks practitioners through decision making, starting with assessment, intervention, and then all the way through to what you should do. So I'd like to just, the guideline itself recommends using a risk factor abatement strategy to reduce both the actual number of falls as well as fall risk factors. So in a risk factor abatement strategy, you know a person has identified fall risk. However, what your goal is to decrease the amount of fall risk factors. So therefore, the guideline recommends that the assessment looks at identifying the fall risk factors. And in that fall risk assessment, you're going to include things such as a focused history, physical examination, functional assessment, environmental assessment. And within the guideline, it tells you exactly what should be included in each of these assessment areas. So on the resource page, you can download the PDF that has the actual guidelines. And also, as I mentioned, there's a handout for a quick reference for you of the algorithm. Next, I'd like to transition into showing you about another tool that was developed based on the AGS-BGS guidelines called the STEADY tool, and that was developed by the CDC. STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. And this is a toolkit that's comprehensive, but more importantly, easy to use in terms of designing resources for you to use that you can incorporate both fall risk intervention and assessment into your clinical practice. So I'd like to actually take you to this website so that you can see how easy it really is. At least that's what we will hope to do. Well, if it doesn't go there, this toolkit provides you with forms, checklists, and training videos that you can use to make sure your assessment is comprehensive and multifactorial. So I'll give you just a few examples, and I would encourage you to go to that website. So in the Integrating Fall Prevention and Practice checklist, there's a list of all the different areas for both assessment and intervention. So it included in the checklist, it also has a space where you can assign and decide who's going to be in charge of that. Okay? And then it also has specific examples of what should be in there. So here's an example. The physical exam is one of the areas to be assessed. This checklist suggests, in addition to your customary physical exam, that you would also include muscle tone assessment, screenings for cognition and depression, and a feet and footwear evaluation. There's also something called the Stay Independent brochure. It's a self-report checklist that your clients can fill out looking at various risk factors. So again, that intrinsic, environmental, and behavioral. So this is something that practitioners can use to review with their clients. And it's a great way to kind of start that discussion about fall risk. Both of these checklists have been included in your handouts as just an example of some of the nice resources that are available to you. The website also has recommendations for standardized assessments, and in those they actually have training videos, the actual assessment form, and instructions on how to administer those assessments. There's also an environmental assessment that you can use, and finally, it also has a number of resources. So it has a sample home exercise program and some recommendations for community-based programs. So I'd encourage you to look at that website. So now that we've talked a little bit about the assessment piece, I want to transition now into the types of fall prevention. So we'll start with here. There are 3 types of fall prevention interventions. So we have single, multiple, and multifactorial. The AGS-BGS guidelines recommends a multifactorial approach. And what that is that's a combination of interventions that are specific to a person based on an individualized assessment. So for example, if a person is found to have fall risk factors, which include muscle weakness, postural hypotension, and environmental hazards, then the intervention that would be most appropriate for them might be an exercise or program. It might be medication management and thinking about home modification. So within the guideline, there are also summaries for each of those interventions as ideas of what you can include there. So while the guideline recommends a multifactorial approach, I do want to highlight a few single and multiple interventions that are evidence-based and readily available within community settings. So exercise is one of the most common and evidence-based single interventions. And a recent meta-analysis by Sherrington recommended that exercise programs which focus on fall prevention should provide a moderate or high challenge to the balance and be used at least 2 hours per week on a regular basis. Okay, so 2 programs that you might know about that are actively disseminated by the CDC is the Tai Chi, Moving for Better Balance, and also the Otago Exercise Program. So another option for you is going to be a comprehensive community-based multiple intervention. And these are ones where everyone, regardless of their fall factors, are going to receive the same content. Okay, so in this case, maybe exercise, a component of medical management, medication adjustment, and then education. So I want to tell you about a couple of those. So both Stepping On and Matter of Balance are evidence-based programs that are widely available across the nation. Stepping On is actually, just like Tai Chi and the Otago, is being actively disseminated by the CDC. And the Matter of Balance is available in 34 states, which includes Tennessee. And it has reached over 50,000 older adults. An interesting fact about Matter of Balance was in a report to Congress from 2013, looked at evaluating community-based wellness and prevention programs. Matter of Balance was one of the 4 programs that was shown to potentially decrease healthcare utilization and healthcare costs to the participants. So finally, I want to highlight one additional intervention to consider. So fall risk can be considered a chronic condition because it requires ongoing assessment and intervention. And a self-management approach has been proven to be effective in managing chronic conditions. So while self-management has traditionally been used with chronic conditions such as COPD, arthritis, diabetes, I'd like to suggest that a self-management approach could be applied to fall risk as a complement to the other interventions that you offer. So as a way of background, self-management is what people do in order to manage the impact of chronic conditions, because we know that many of the decisions that are made daily related to symptom management is not done in our offices or in our medical facilities. It's done by the person in their home, right? So what self-management includes is a broad set of attitudes, behaviors, and skills. Self-management support refers to what healthcare professionals do to assist their clients. So health professionals, we don't self-manage, but what we do is we support our clients as they self-manage through education, information sharing, and skill development. So as mentioned in the last slide, self-management is what the person does. And this includes the development of specific skills that they can use to better manage their chronic conditions. So while there's some variation in the literature as to what the exact skills are, the most common are symptom monitoring, problem solving, decision making, action planning, locating and using resources, and communication. And with each of these skills, there's a very specific, structured way that the person uses this skill. So while there's the potential for a person to develop any of these skills related to fall prevention, I'm going to just provide you with one example, and that's action planning. So action planning is a structured way of developing a short-term plan in order to accomplish something the person wants to do. So this is more than just saying, well, how do you want to decrease your fall risk? Or what are you going to do to make yourself safer so that you don't fall? But instead, the plan outlines a specific action or set of actions that the person can realistically expect to accomplish in about a week or two. So this was a form that was developed originally to help clients with general chronic condition management. However, I modified it to be specific to fall preventions. And what you see here is the interventions that are suggested at the top are consistent with the AGS-BGS guidelines. So the way that this would work is a healthcare professional and client would collaboratively complete this form together. Then the person goes home, implements the action plan, and then the healthcare professional can follow up to see if the action plan was met. So again, an example for you. A client decides to modify his home environment, specifically changing light bulbs in a dim hallway. Okay? So while filling out this form is not a guarantee that he's going to go and change his light bulbs, what it does do, hopefully, is by answering these follow-up questions, such as what are you specifically going to do, how many light bulbs are you going to change, when will you do it, and how confident are you that you're actually going to do this, there's a higher probability that they actually will do this. And so this particular form is also included as a handout for you, and you're welcome to reproduce it and use it without need for permission. So in summary, the AGS-BGS guidelines have provided very clear recommendations for fall prevention evaluation as well as intervention. Fall prevention interventions can be provided either at a single, multiple, or multifactorial combination. And there are a number of great fall risk resources available for you to help guide you. So just to let you know, there's 2 more handouts that were provided. The first one is just a resource page with a number of websites, links, and things like that you might find helpful. And the other one is a sample fall prevention assessment and intervention protocol that you could possibly modify or implement within your facility. This protocol includes recommendations for screening and includes questions to ask. It has standardized assessment recommendations so that you can include those in your multifactorial fall risk assessment, and then also some recommended programs that are both evidence-based as well as widely distributed around the nation. So thank you.
Thank you so much to our panelists. At this time, let me open the floor up to any questions that you may all have. Or forever hold your peace. None? Okay. Go. The question is about exercise programs.
Sure. You're talking specifically about the ones that are disseminated by the CDC. Absolutely. You can go on the website, the CDC website, which is linked to the study, and you can find that information. You also could Google it, and they'll come up on how to find that information. If you can't find it after that, you're welcome to email me, and I have the contact information for the two people who are in charge of disseminating those.
Okay. Anybody else? Yes, ma'am.
So the question was regarding when you have a patient who's on multiple medications, how do you go about deprescribing and peeling them off? Do you stop them all at the same time? It's really going to be on an individualized basis. And like I discussed in the example today, if it's hypertension related, it really depends on how hypotensive are they. If it's an urgent need, we are going to stop medications as quick as possible without causing any rebound hypertension. But in other matters, it also depends on if a medication should be tapered off or not. So the best answer I can give you is that it is going to be individualized based on the patient and the circumstances surrounding the need for discontinuation of those medications. And their doctors. Yes.
Okay. Any other questions? None? Okay, we have one more here.
Getting approval for home health services to start, what would be appropriate to put down on the face-to-face evaluation in order to justify occupational therapy specifically? That seems to be the hardest to get in the home. What would you recommend?
Right.
Let's say a person is falling and we would like to get OT involved. What can we put down?
Sure, absolutely. Well, I would start first with, if you're in the medical system or if you're in an acute care hospital, start by with a referral to OT services, right? Because they're the ones, once you start the services within the hospital setting, much easier than to recommend a home evaluation, because then they can kind of talk about the concerns, but within a home environment, you can really look at those situations a little bit more carefully.
Any final questions? If not, okay, one more, ma'am. Go ahead.
Many of the Medicare plans include what they call, they give you a card, it's called Silver Sneakers. And so my question is, in some of the facilities like the YMCA and so on, do they include specific kinds of exercises related to some of the things you've been talking about for persons who have that I have one. Like Cigna Health Spring, for example, provides, it's part of the package deal. So are you aware of whether these facilities provide, do they think specifically about individuals falling and provide some support for that?
I'm not familiar with the Silver Sneakers program, but I would guess in general, if you look at community-based programs like the YMCA or something like that, they probably are not familiar with specifics related to recommendations for exercise and things like that. I think that's a great way, just as a community person, you can educate those. If they are, maybe that there's, I don't know those particular programs, so there may be some training that they have to have in order to be certified as a Silver Sneakers program. Maybe someone else in the audience knows better than I. Yeah.
Okay, we have it here.
I know the Y does have, the silver sneakers is specific for the YWCAs, and they have accredited trainers, they have on-site physical therapists, and they do have levels. They even have a balance class for older adults that are in their 80s to help them. So they're very, very good at that.
So it sounds like if that's the case, you know, they're being trained through a program that's, I'm sure, has some sort of connection to the American Geriatric Society, is I would guess, but again, I don't know for sure.
Okay, and the gentleman's comment back here.
I think it's real individualized. Like some Ys will offer the Tai Chi for movement, so price tend to check with whatever facility. I know that a lot of places here in Nashville offer that.
One more comment, ma'am.
I like to ask a question is how the physical therapy relieves the pain, since in the former section, pain management is physical therapy is as option, treatment option for pain. So how, since I don't understand very well how the physical therapy relieves some patients' pain, I mean.
So help me understand your question. Let me parrot it back to you. You're asking about how physical therapy and pain management influence falls. Is that what I heard, or is it?
No, this is not related with fall, but as I heard from the former section, the physical therapy as one of the treatment options for relieve pain. So I like to ask, is there any examples for the patients? What kind of patients, they have pain, can be relieved with physical therapy?
Okay, sure. So the question basically deals with how physical therapy manages pain.
Yes, right.
Okay.
Thank you.
Yeah, thank you for the question. I think with physical therapy, we first have to start with, obviously, an important aspect is the evaluation. What type of pain do they present, and what type of impairments do they come with? Because I think that's important. In physical therapy, when you dissect the term, therapy means treatment, and physical means the use of physical agents or physical modalities, such as exercise, manipulation, and so forth and so on. So I think the whole thrust of physical therapy is being able to use some type of physical agent or manipulation to manage pain. And so, there have been evidence on certain impairments being effective with the use of certain modalities. So depending on what the patient comes in with, then we have to then address it at that level.
Yeah, maybe, no, I'm thinking it could be some heat or some,
sure.
For example, somewhere is pain and with a heat here or something like that.
Exactly. Part of symptomatology or symptomatic treatment is the use of physical agents, the use of heat and cold and things of that nature. But I think beyond physical therapy, the American Physical Therapy Association released a paper just in the past 3 weeks that talked about physical therapy not only being using passive agents, but being able to use passive agents in promoting function. So we go beyond just the use of heat and cold and things like that. But how do we, after using that, promote function at a level that the patient can do, considering the pain and the pain relief that hopefully the patient will have? Okay. Any other questions? If not, let's thank our panel again. Thank you.